Thank you, Mr. Chairman. Good afternoon. It's a great honor. I was given the chance to review the clinical aspect of percutaneous mitral valvuloplasty. Let me call it PMV in brief from now on. It is well known that the incidence of rheumatic fever is decreasing worldwide. In Americas and Europe, they have long been low in incidences. In other countries, especially in developing countries, they have been rapidly decreasing. Regarding rheumatic heart disease, the prevalences, except Europe, are increasing. This is partly because the rheumatic heart disease is latent sequelae of previously prevalent acute rheumatic fever. And another explanation is the development and improvement of diagnostic abilities, such as echo. In our hospital, we have performed 770 cases of PMV. We started PMV in 1989, and it was one of the hottest interventional procedures until early 2000s. During the last decade, the numbers are small but still steady. Mitral valve is the commonest valve affected by a rheumatic process. Severe mitral stenosis causes dyspnea, pulmonary hypertension, right heart failure, peripheral edema, atrial fibrillation, and systemic embolism. In addition to medical treatment, surgical mitral commissurotomy was a traditional treatment to relieve the flow obstruction. The closed commissurotomy started since 1940s, open commissurotomy since 1960s. PMV was introduced in 1984. In 1984, Kanji Inoue, the Japanese cardiac surgeon, firstly reported the idea of PMV using his unique balloon. Others introduced PMV techniques using various types of balloons. This is the prototype of Inoue balloon. PMV is commonly performed using double balloon or Inoue balloon. Compared to double balloon, Inoue balloon has some technical advantages. It is easy to use, short, flexible tip, no need of left ventricular wiring. Stepwise dilatation is possible and allowing direct left atrial pressure measurement. And the short and long-term results were the same. So Inoue balloon has become more popular balloon for PMV. Like closed commissurotomy, the main mechanism of PMV is splitting commissures remotely and blindly. So the immediate results were not always as expected. To predict the results before PMV, Wilkins searched predictors from mitral valve morphologies. With echo, the mitral valve leaflet rigidity, thickness, calcification, and the subvalvular thickness were scored. When the optimal result was defined as final mitral valve area greater than 1.5, no more than moderate mitral regurgitation, the low echo scores were more related with optimal results. The high echo scores were more related with suboptimal result. This study shows total score greater than 10 was highly predictive of occurrence of severe mitral regurgitation. 7-year follow-up data shows the lower the echo scores, the better event-free survival, and the higher the echo scores, the worse the event-free survival. But this scoring system does not have any information about commissures. As I said, the main mechanism of PMV is the splitting commissure. So the commissural classification should be accounted for another predictor. This is one example of commissural classification. The anterolateral commissure is heavily calcified after PMV. Significant mitral regurgitation occurred at the medial side of commissure. This study showed commissural calcification was associated with less than 50% probability of achieving optimal mitral valve area and more need for valve replacement. When event was defined as death, mitral replacement, or repeated PMV, presence of commissural calcification showed poor event-free survival at 3 years. After all, the success of PMV depends on the pliability of leaflet complex and the commissural calcification. There are a lot of studies evaluating short and long-term outcomes. Most studies showed excellent immediate results. Mitral valve area doubled, the LA pressure, transmitral pressure gradient, pulmonary artery pressure rapidly decreased, and the cardiac output increased. This 7-year follow-up data shows the composite endpoint 5-year event-free survival was more than 70%. This graph shows yearly mitral valve area loss. Year by year, the average mitral valve area decreased at the rate of 0.025 square centimeters per year. This is 20-year follow-up result. The green line is free from surgery survival. The red line is free from PMV survival. Almost half of the patients who, after successful PMV, remained free of surgery, even though some patients should be treated with repeated PMV. Let's compare PMV with the surgery. Compared to open mitral commissurotomy, the PMV shows in mitral valve area comparable to open mitral commissurotomy throughout 3 years. And the transmitral gradient, exercise capacity were also comparable. Complications were not so seriously different in both groups. In other study, the PMV, open mitral commissurotomy, closed mitral commissurotomy were all compared. The achieved mitral valve area were good in PMV and OMC, which were even better than CMC throughout 7 years. They concluded that PMV and OMC have comparable initial results, low restenosis rate, and good functional capacity for at least 3 years. Better hemodynamic results, lower cost, and elimination of need for thoracotomy suggest that PMV should be considered for patients with favorable mitral valve anatomy. In 2014, ACC/AHA valvular heart disease guideline suggested indications for intervention for rheumatic mitral stenosis, severe mitral stenosis, symptomatic severe mitral stenosis with favorable valve morphology without contraindication for PMV. PMV was indicated as class 1 recommendation. If the valve morphology is not favorable for PMV, without a high surgical risk, mitral valve replacement is recommended as class 1 indication. If the surgical risk is high, even though the valve morphology is unfavorable, PMV may be considered as recommendation 2B. Persistent left atrial thrombus or more than moderate mitral regurgitations are absolute contraindications to PMV. The following are relative contraindications. Important PMV complications are hemopericardium, systemic embolism, or severe mitral regurgitation. PMV may be applied for special patients. In patients with restenosis after surgical or balloon commissurotomy, some reported repeated PMV showed a safe and favorable outcome. Some reported a less favorable outcome compared to mitral replacement in terms of long-term event-free survival. Some showed same immediate result with the de novo PMV, but less favorable long-term event survival. When severe TR is combined with mitral stenosis, PMV was compared with surgical mitral valve replacement and tricuspid valvoplasty. The 7-year follow-up shows the PMV group had poor event-free survival, especially when they have atrial fibrillation. PMV group showed more heart failure admission. 1-year echo follow-up showed more in PMV group, more than half of patients had still had a significant TR, contrary to nearly no TR in surgical group. During pregnancy, the maternal and fetal mortality, morbidity are substantial during labor or during surgical commissurotomy. So PMV may be considered, especially during second trimester of pregnancy. I'd like to summarize here. The incidence of rheumatic fever is decreasing worldwide, but substantial occurrence exists in developing countries, and the prevalence of rheumatic valvular heart disease is steady or increasing. Immediate long-term PMV results are acceptable when it is performed in patients with favorable valve morphology. Echo score and the commissural calcification are important echocardiographic predictors for outcome. PMV may be considered in patients with high surgical risks, even with unfavorable mitral valve morphology. PMV might be first-line treatment in special clinical situations. Thank you very much for your attention.